Hello, everyone, and welcome to tonight's webinar on updates on endovascular therapy for acute ischemic stroke. I'm Joe Marion, the RFS Neuro Service Line Chair. Since this is our final webinar in the series on stroke intervention, I'd like to take a second to thank all of you for attending the webinars and expressing interest in learning more. The webinars will be posted on the RFS YouTube channel in the coming days, and I'll let everyone know who has registered for any of the webinars when those will be available. I'd like to remind everyone that if you have any questions along the way, to type them into the question box on the right-hand part of the screen. And feel free to submit those questions at any time, and then we'll cover those at the end of the presentation. Tonight's presenter is Dr. Venu Vadlamudi. He's a practicing interventional radiologist at Innova Hospital in Alexandria, Virginia. He went to medical school at St. George's University School of Medicine, completed radiology residency at Michigan State University, interventional fellowship at Beaumont Hospital in Royal Oak, Michigan, and finally a neurointerventional fellowship at University of Michigan in Ann Arbor. He is a strong advocate for IR and stroke care, and tonight he'll be discussing updates on endovascular therapy for acute ischemic stroke. With that, I'll turn it over to Dr. Vadlamudi.
Thanks so much, Joe, and thanks to everybody in the resident and fellow section for not just your participation in this series that's come together over the last several weeks on stroke and stroke-related issues, but just in general, it's really, kind of always a breath of enthusiasm and fresh air to see the interest of, residents and fellows, medical students, and so I'm very happy to participate in this, and, not too long ago, I was in your guys' shoes in the resident fellow section, so very happy to contribute in any way I can. That being said, I know the other night you guys had a very nice talk from Sabine Don, talking about IR perspective on stroke care, and then certainly he showed some very nice cases and neuroimaging, and I thought really from a almost completion standpoint, it's good to sort of get through a lot of the different trials that have, kind of led us to where we are today, where endovascular treatment for acute stroke is truly a standard of care. But I think it's important to kind of understand the trials and the data, be able to sort of understand the lingo, if you will. And so I thought this would be a good talk to just sort of round out the series. So with that, we'll go ahead and start my presentation. As Joe had mentioned, I practice full-time interventional radiology split between body interventional and neurointerventional. I'm also the director of stroke and cerebrovascular services at Innova Alexandria Hospital. Here are my disclosures, no financial disclosures. I do participate in some research trials and an unpaid consultant for Stryker and Merit. So the objectives of tonight's talk are to review what we now consider the early window endovascular stroke trials. And then more recently, there's been these what are called extended window endovascular stroke trials, and then get a glimpse into forthcoming trials and maybe some future directions as far as where stroke therapy and specifically endovascular therapy for stroke may be going. So briefly, I know this probably has been common amongst multiple different talks, but sort of never hurts to see these numbers again, just to kind of imprint them in your mind. Stroke still remains the #1 cause of disability. It's the #5 cause of death in the US. It has dropped down over the last several years from the #3 cause of death, but still very high up on the list, behind certainly common things like cancers, for example. Still about 800,000 strokes per year. There's an estimate that perhaps 80% of these could be preventable with cardiovascular risk factor modification. So a lot of that certainly goes into play when you're seeing patients with peripheral artery disease. Just think of them as, well, those are patients that are at this equally high risk of stroke and vice versa. A lot of strokes occur, unfortunately, in patients who have had prior strokes. So that's its own independent risk factor for another stroke. And some of these statistics about every 40 seconds, someone in the US has a stroke, and every 4 minutes, somebody dies from a stroke. And of course, looking big picture and looking at some of the finances, well, it costs a lot of money, both in terms of direct costs to the healthcare system, which are continuing to go up and up, but also indirect costs. If you think about loss in productivity, time off from a job, recovery time, or perhaps an inability to return to your normal function or even way of earning a living, stroke certainly can still cost a lot to society as a whole. When we look at risk factors, just like cardiovascular disease in general, but kind of some specific ones with stroke, we again break it down to modifiable and non-modifiable. Stroke risk doubles with each decade. It's not that a young person cannot have a stroke, it's just less common, although that has been actually increasing, unfortunately, over the last several years. But certainly older patients are at higher risk for stroke, and that's typically what we come across. Men more than women at younger ages, but then it sort of reverses at older age, and frankly, part of that is just sort of survival. More women tend to live longer than men. African American patients are at about twice as high risk of stroke compared to whites. Asians seem to have a lower ischemic stroke risk, but seem to be a little bit higher for hemorrhagic stroke risk. And family history. So if a parent had a stroke below the age of 65, you yourself have a threefold increased risk of stroke. And then certainly there are modifiable things. A lot of them we already, of course, know about, all the common kind of players, if you will. But again, it's all of these certainly tie into other diseases such as AAA or peripheral artery disease, et cetera. So all the more reason to get those under control for our patients. Ischemic and hemorrhagic strokes, again, this is probably repetition in a sense, but ischemic does represent the vast majority of stroke cases, and some estimates have up to maybe even a third of them being due to occlusion of what we consider large vessels or large arteries. Probably the statistics may be closer to 10 to 15%, but perhaps we don't quite know the magnitude. And a lot of them are due to emboli. So atrial fibrillation, for example, causing a stroke is certainly a very common scenario, but other risk factors such as extracranial carotid disease or even intracranial atherosclerotic disease can cause stroke. I have a slide coming up about sort of the breakdown of, well, how many connections and neurons and things die every second, every minute, but bottom line, it's a lot, and we'll look at a little bit of the relative brain aging that occurs. Hemorrhagic stroke, which is not a focus of tonight's talk, represents the minority of cases with things like subarachnoid hemorrhage or intraparenchymal hemorrhage. Intraparenchymal hemorrhage being, again, commonly associated with things like hypertension, again, a risk factor that we can try to modify. Subarachnoid hemorrhage we typically think of relating to aneurysmal disease. As I mentioned, this is sort of the breakdown, this is sort of a famously quoted paper by Jeff Saver from UCLA, where he was able to sort of, in essence, extrapolate what is happening during a stroke at each second, minute, hour, etc., and looking at neurons that are lost. And of course, each neuron has multiple synapses, and the myelinated fibers, how much fibers are you losing, and relative brain aging that occurs during a stroke. So you can see with each minute of a stroke, the brain is aging by weeks. And so that is very significant. It's not just that almost 2 million brain cells are dying, but you're losing billions of connections, and the brain is actually literally aging. And so I do keep a little bit of this in mind when pushing through and trying to rapidly triage, assess, and revascularize a patient having an acute stroke, especially if you look at a large vessel occlusion stroke. I mean, you're literally potentially aging the brain by decades if you do nothing or aren't able to get the vessel open. And so these are some of the things that are in the back of my mind. Every minute, and a minute in a certain sense doesn't seem like a long time. In a certain sense, it's a very long time. And so that's, I think, part of what I, like I said, keep in mind during these cases. So with that as a bit of background, we'll start to talk about some of the 2015 endovascular stroke trials. Some of these names or acronyms you may have heard of: Mr. Clean, Escape, Extend IA, Swift Prime, and REVASCAT. But before we kind of get into that, I want to sort of just again review some definitions. Some of these have already come up in prior talks, but again, never hurts to sort of review them, just because they are, of course, prevalent throughout all of the endovascular stroke trials. So I think it's important to be able to sort of talk the talk, if you will. So aspect score, that is this specific scoring looking at the non-contrast CT of the head, developed, out of the Calgary program in Alberta, Canada. TICI, this is sort of our derivation and borrowing from the cardiac world, where they have a TIMI score, thrombolysis in myocardial infarction. So we borrowed and modified that to call TICI in cerebral infarction. And then MRS is a modified Rankin score. That's a sort of a scale looking at relative functionality. Again, in all of the endovascular stroke trials, this was a measure certainly for outcomes at the 90-day mark, but also a lot of them used it as a selection criteria as a pre-stroke functional status. So we'll talk about that with some of the different trials. As I mentioned, the aspect scoring system looks at the non-contrast CT of the head, divides the MCA territory into 10 distinct areas, and the maximum score in a normal brain, as far as normal gray-white matter differentiation, has an aspect score of 10, and the absolute worst is an aspect score of 0. And in essence, for each of the individual areas where there's loss of gray-white matter differentiation, you subtract a point from that 10-point scale. So again, just to sort of understand this background, since it comes up in almost all of the different trials. The TICI score, as I mentioned, really kind of the two to keep in mind, because these were considered as angiographic good outcomes or desired outcomes in the trials, were TICI 2B and 3, which means that basically you've gotten the vast majority of the branches opened up, and maybe there's some very distal emboli or slow flow areas, and which is TICI 2B, or TICI 3, which is complete reperfusion, completely normalized flow. There's no evidence of any kind of distal obstruction or embolization. So that's kind of what we consider as angiographically good success. There are variations of the TICI scoring system, original TICI, modified TICI. So these are some of the things that you may see in other literature out there. But TICI 2B and 3, just because that will come up in all of the trials, is kind of what to keep in mind. The modified Rankin score, as I was mentioning, it was a scale to look at outcomes in basically all of the endovascular stroke trials, and many of them used it as a selection criteria for patients who would be enrolled in the trial. Really, if you look at 0 being completely normal with no symptoms, 6 is death. 0, 1, and 2 were considered in basically the majority of the trials as what was a desirable or good outcome. So 1, I always kind of consider as a patient who may have minimal disability that more often than not they probably notice and may not be necessarily readily apparent externally. A modified Rankin of 2 is a slight disability, something that you probably could notice from the outside, that, for example, maybe their arm's not that strong, they sort of need some assistance with that one arm, but otherwise they're back to work and doing their own affairs and taking care of themselves. So that's something like a MRS of 2. MRS of 3, 4, and 5 is, varying degree and worsening of disability. 4s and 5s are really kind of very severely disabled, if you think of it, unable to take care of themselves independently. They require constant care. And some patients will, almost tell you outright that they would rather be either dead or functional and independent. But, if you sort of leave them the choice that, well, you would be severely disabled, that's almost worse for them than death. I've actually had some patients sort of say something along those lines. So at the end of the day, as I mentioned, 0, 1, and 2 are what we consider good functional outcomes. And that was what was often included as far as the clinical endpoint in the trials. So with that as the background, we'll start with the kind of probably biggest or most pivotal trial of the recent era, which was the Mr. Clean trial. This was completed at the end of 2014 and published in the very beginning of 2015, and kind of had this domino effect on multiple other trials. And if you kind of look at this trial, it was really a practical trial done in the Netherlands. It was a randomized controlled trial done at 16 different centers. They selected for adult patients, no cutoff as far as the pre-stroke modified Rankin score. They basically allowed for almost anybody to be included as far as from a functional status before their stroke, and even from a stroke severity standpoint. They said an NIH stroke score of 2 or greater. 2 is fairly minimal in the NIH scoring system. They had no minimum aspect scoring cutoff. They utilized a CT angiogram in order to confirm the large vessel occlusion and went for a goal treatment time within 6 hours of last known well. And they randomized between medical management, which included in the majority of cases IV alteplase or TPA, and the thrombectomy arm, which again, if they qualified to get IV TPA, they would get it, and they would move on to thrombectomy if the CTA, of course, confirmed that there was a large artery occlusion. The practical sort of nature of this trial was that the healthcare system in the Netherlands is a centralized healthcare system, and so the government, in essence, said, well, we're not going to pay for these thrombectomy devices until you can, in essence, prove that it actually works. So that was really the bottom line basis for this trial, was, in essence, to prove what we were doing in the stroke thrombectomy world was actually working to help patients. A bit of background behind this was that just a couple of years prior, in 2013, there was 3 trials that came out in the New England Journal of Medicine, all in the same issue. And they basically said that endovascular treatment for acute ischemic stroke was, in essence, no better than IV TPA. Certainly critiques and criticisms of those trials, but that was the sort of starting point, if you will, just a couple of years prior. So as you can imagine, it's not unreasonable to say, well, let's prove that this really works, because so far the data is not that great about it. But nonetheless, that's what the basis for this trial was. And if you look at the breakdown, the median aspect score was 9, so kind of good-looking brains on the CT of the head, but fairly severe stroke scores. NIH stroke score of 17 was the median. They used stent retrievers in 97% of cases, didn't necessarily specify any particular brand, but that just happened to be what they used as far as what kind of devices they used. They achieved that good revascularization rate in 58.7%, that TICI 2B or 3 revascularization. And then at the 90-day mark, when you look at the modified Rankin of 0, 1, or 2, 33% achieved that good clinical outcome in the endovascular arm versus 19% in the medical management arm, which was statistically significant difference. And so the conclusion was that there's significantly better outcomes with thrombectomy as compared to medical management. And so this trial, again, it enrolled 500 patients, really kind of set off quite a bit of a domino effect, as I mentioned, where other trials that were concurrently ongoing actually had to sort of take pause and say, well, let's analyze. And their sort of data safety and monitoring boards and internal reviews looked and stopped and paused, and they actually found that really they were getting quite similar results. So this was a very pivotal trial with a domino effect on multiple other trials. Here's just a graph showing kind of the relative shift and with improved outcomes as far as the modified Rankin scale at 90 days. And what you can see is not just the 0, 1, and 2s, but even in a certain sense, the 3s and 4s, you have sort of a relative shift where, granted, they may not be considered as a good outcome, kind of quote unquote, but that's probably a better outcome. So if somebody ends up as a modified Rankin of 3 instead of being a modified Rankin of 4 or 5, well, that's a relative shift in the right direction, perhaps. And so that's, I think, another thing that you'll see in a lot of the different trials. And so, as I mentioned, these other different trials were ongoing. ESCAPE was a trial run out of the group from Calgary. Mayank Goyal was the primary investigator in that trial. And so this one looked at endovascular treatment, but they had a sort of slightly different flavor of this trial, where not only they had a few kind of pre-selection criteria, such as the pre-stroke modified Rankin score of 0 or a 1, so kind of selecting for people who are already independent, unlike the Mr. Clean trial where they sort of allowed for all comers. NIH of 5 or greater, aspects of at least 5, so that means that at least in essence half of that MCA territory was still looking okay on the initial dry CT of the head. And they did something what's called multi-phase CTA. So that's a CTA of the head and neck, followed by repeat imaging through the head without additional contrast injection. You're basically looking at the blood flow through the vessels and the collaterals through the brain itself and getting an idea of what the collateral vessels look like. And so it's sort of almost a dynamic CTA in a sense. They allowed for treatment within 12 hours of last known well. They got up to 315 patients, but halted early because of their internal review. Again, especially after the Mr. Clean trial came out, had a fairly equal split between the two arms. And again, almost really mirror image type of data in terms of the median aspects and NIH stroke score across both arms. Stent retrievers were used in the vast majority of patients, and they achieved this, again, good revascularization, angiographically speaking, in 72.4% of patients, with, again, statistically significant difference in clinical outcomes at 90 days as measured by the modified Rankin score, 53% 0 to 2 in the endovascular arm versus 29% in the medical management arm. Again, the conclusion is then really the same, significantly better outcomes with thrombectomy as compared to medical management. So another randomized trial that showed the same outcome, done with slight variation, if you will, in how they enroll patients. Again, here's sort of the breakdown of their data, again, showing that not only better 0, 1, and 2 modified Rankin outcomes, but also this relative shift of some of those 3s and 4s perhaps. So again, some of those patients may not be totally independent, but perhaps they have less disability after their stroke. The Extend IA trial was done in Australia. Bruce Campbell was the PI of that trial. That one was a little bit different because they wanted to use perfusion imaging to help kind of identify who might be an optimal candidate. So as I mentioned, 14 centers across Australia and New Zealand. No minimum NIH stroke score. They did, want a pre-stroke modified Rankin of 0 or 1. No minimum aspect score, but as I mentioned, they used not only CTA to help identify the large artery occlusion, but CT perfusion imaging, which I know Sabine had talked about in his talk the other night. And that kind of looks at, well, what does the perfusion imaging look like to the brain in the sense of area of penumbra or ischemia, and the perceived area of completed infarction. And they actually used a specific software package called the RAPID software, which was originally developed at Stanford. In essence, it's an automated way of identifying core infarct and the relative area of penumbra or ischemia that you're hopefully going to be able to salvage. They wanted treatment within 6 hours of last known well. They also halted early, although smaller numbers between not only both arms, but of course in total. But again, halted early due to that internal review following the Mr. Clean results. And so if you look, median aspects in NIH is exactly identical. They used stent retrievers in 100% of their cases. That was just part of their trial design, that they wanted to specifically use that technology. Achieved good revascularization in 86.2% of the endovascular cases. And again, statistically significant difference with much better outcomes in the endovascular arm as compared to the medical management arm. So the conclusion remains the same, even though, again, slightly different variations of how they selected for patients, for, in this case, using perfusion imaging, mandating use of stent retrievers, for example, but nonetheless, the outcomes are ultimately the same. So again, the scales that they had as far as their outcomes between the endovascular and alteplase only arm, again, showing that the endovascular group fared far better than the IV TPA alone arm. The SWIFT Prime trial was a multi-center trial done throughout North America and Europe. Jeff Saver, as I mentioned from one of the earlier slides, who sort of broke down how many neurons and connections are dying each second and each minute of a stroke. He was the PI of this trial. And so this trial, again, a little bit different. They wanted to specifically use the solitaire stent retriever device. So this was a funded trial by industry, by Medtronic, but nonetheless, kind of quite similar type of criteria as far as who to select, what sort of imaging criteria they were looking for, aspects of 6 or greater, CTA or MRA to confirm the large vessel occlusion. Did not mandate perfusion imaging be done as part of their trial algorithm. Treatment within 6 hours of last known well, and again, halted early at 196 patients with an equal split between each arm. Really, almost now it's sort of a broken record in a sense. Of course, they did use the solitaire stent retriever in 100% of the cases. Well, solitaire was part of the name of the trial, and that's what it's sponsored by. But nonetheless, that particular stent retriever was used in this trial with very good results, TICI-2B and 3 of 88%. And again, that statistically significant improvement in patient outcomes between the endovascular and medical management arm with the same conclusion. Here's the sort of outcomes data in their trial. And then finally, the REVASCAT trial, one of the sort of last ones from 2015, also published in New England Journal. This was done in the Catalonia region of Spain, and Tudor Joven, who's actually at University of Pittsburgh, was the PI of this trial. But nonetheless, they looked at, well, what can they do in their sort of little part of the world, if you will. And so 4 centers in Spain with these sort of criteria as far as who would they select for aspects of at least 7, treatment within 8 hours of last known well, again halted early due to loss of equipoise between the 2 arms, so 103 in each of the arms. And very similar kind of numbers. The median aspects was a little lower than the previous 4 trials, aspects of 7, but an NIH of 17, again, exactly in line with the other trials. They were also sponsored by Medtronic and Solitaire, so that's what was used in 100% of the endovascular cases. Again, very good revascularization rates and statistically significant difference in outcomes with better outcomes in the endovascular arm. So again, the same conclusion. Here's the breakdown of their outcomes data. So with the rapid fire kind of production of these trials in terms of the publication back to back to back in the New England Journal of Medicine, so 5 randomized controlled trials done slightly differently, although with a lot of overlap, but nonetheless, you are coming up with the same conclusion very clearly, statistically significant. Well, it forced the American Heart, American Stroke Association to kind of very quickly revise their guidelines. So at the 2015 meeting, I can tell it was a very exciting meeting because we knew these trials were happening. They were getting announced sort of live in a sense. And so they quickly had to revise their guidelines because from the 2013 trials that had occurred, it was hard for them to say that patients really do better with endovascular treatment. But now suddenly we have 5 different randomized trials showing very clearly, no, they clearly do better. And so that's what they gave a level 1A recommendation for treatment up to 6 hours since last known well for anterior circulation, large vessel stroke. So that's kind of an important point in the 2015 guidelines because that was what was included in all of those trials. There is a little bit of a change or difference in the more recent 2018 guidelines, which we'll talk about. But that being said, with all of that overwhelmingly positive data, well, there was these other trials that were still going on and even a meta-analysis of data. So there was yet more data coming. And so when we look at the 2016 trials, therapy, Thrace, and PISTI, and then finally what's called the Hermes collaboration, that's really a meta-analysis of the especially 2015 trial data. So the therapy trial, this was a little bit different in one sense of, number one, specifically using the penumbra aspiration catheter system for stroke. And also one thing that was quite different than really any of the other trials was looking for the specific clot length. There's some data that shows that in essence, the longer the occlusion of, let's say, the internal carotid or middle cerebral artery, the worse the outcomes may seem to be. And so they wanted to kind of have that additional kind of unique aspect in this trial, looking at the clot length greater than 8 millimeters in length. They ended up halting their trial early. They split patients between, of course, the 2 arms with IVTPA versus IVTPA plus thrombectomy. So that's why they kept it to patients within 4.5 hours of last known well, so that really almost all of them should be getting IVTPA because they should qualify. And so based on this trial, they had no sort of minimum aspect score, but most, when we look at the actual data, were greater than an aspects of 5. Interestingly, the penumbra aspiration system was used in most, but not all of the endovascular cases. So despite sort of being this sponsored trial using or looking at the specific system, it wasn't necessarily used in every patient. So that was a little bit interesting, but nonetheless, they had good angiographic revascularization, 70% TICI-2B or 3, although some of that was after additional devices or techniques were utilized outside of just the aspiration system alone. They failed to meet their primary endpoint, but there was a trend, albeit not statistically significant as far as the difference, but a trend towards a better outcome in the endovascular versus the medical management arm. So you could make the argument that this trial wasn't positive, but had this trend towards better outcomes in the endovascular arm. The Thrace trial was performed in France, and so they, again, wanted to look at thrombectomy versus medical management. They're sort of now adding in, if you will, another 400 patients into sort of the larger collective data pool of endovascular stroke trials. And, you know, you look at NIH of 10 to 25 as far as the stroke severity, so fairly severe strokes. No minimum aspect score cutoffs, are kind of a bit similar like the Mr. Clean trial, and CTA just to confirm that there is an occlusion. And then treatment within 5 hours of last known well. And of course, if they could qualify for TPA, try to get them to TPA as quickly as possible. Again, most were greater than 5 as far as the aspect score. The median NIH was quite similar as the multiple other prior trials of 18. They didn't have any specific restriction on what kinds of devices could be used. So a variety of thrombectomy devices were employed with a fairly good revascularization rate of 68.8%. Statistically significant difference in outcomes with better outcomes in the endovascular arm. So this trial was positive, akin to the other previous trials. Finally, the PISTI trial was a pragmatic trial done in the UK, and this one had kind of some similarities as Mr. Clean and Thrace. So for example, no minimum aspect score, no kind of minimum pre-stroke MRS. They only sort of stipulated less than 1/3 of the MCA territory has core infarct on the dry CT of the head. A CTA, of course, confirming that there's a large artery occlusion. And yet again, another trial halted early due to positivity of multiple prior trials. So this one stopped at 65 patients. And all of these patients were treated within 6 hours of last known well. Very similar median aspects and NIH stroke scores as the multiple prior trials. Stent retrievers were used in most cases, but they used aspiration, so penumbra system, for example, in about 1/3 of their endovascular cases. Ultimately achieved a good revascularization rate of 87%, TIGI 2B and 3, and again, significantly better outcomes in the thrombectomy arm compared to the medical management arm. So the conclusion ultimately is the same with yet another trial. And this is sort of the data looking at their outcomes, including some of the modified Rankin score shifts. So Hermes, as I mentioned, was this meta-analysis, collaborative sort of pooling of data between initially these 5 randomized controlled trials from 2015. So trying to look and see if there was, you know, with pooling of the data and the patients, added power that can, you know, come up with some additional conclusions or information that can help hopefully more patients. So the pooling of this, all these 5 trials led to almost 1,300 patients worth of data with a fairly equal split, again, between both arms, because all of those trials were randomized between the 2 arms. And this was published in 2016 in Lancet. And so when you look at sort of the summary slides of, you know, the overall outcomes between the medical management or control arm versus the endovascular or intervention arm, those who were ineligible for TPA, those who had received TPA, what we can see is the red representing the control or medical management only arms. Well, there is, for example, there is an improvement in outcomes in patients who receive TPA versus those who cannot. If they're beyond the window, unfortunately, they would not be able to receive TPA. That's something that supports multiple prior trials looking at IV TPA by itself, of course. But at the same time, when you add in the endovascular component, well, we're seeing that there's clearly, as expected, better outcomes in the endovascular arm, whether or not they've received TPA in a sense. So you can sort of start to break down that argument to say, well, even if they didn't get TPA, you're still giving them clearly a benefit. And if they've received TPA, they still derive a benefit. So all the more reason that it's, in a certain sense, endovascular treatment for stroke is really an independent decision of TPA. If they've received TPA, that's excellent. Hopefully they received it as fast as possible. But if they have not received TPA, it should not stop the idea of doing thrombectomy to help them with their stroke, because clearly they'll derive benefit. And so that's, I think, one of the important points from the Hermes data. But it sort of raised a question, a practical one of, is there a certain inflection point of benefit? And so because the different trials, most of them were within the 6-hour last known well, but for example, the REVASCAT trial allowed for up to 8 hours since the last known well, and ESCAPE allowed up to 12 hours. So you had some spread of data across the 6 hours plus timeline. And so what they seem to find is that the inflection point appeared to be at 7.3 hours. So beyond 7.3 hours, maybe we're not really deriving benefit from endovascular treatment versus medical management alone. So that was one of the sort of data points by pooling all of the different trial data together that came out of the Hermes collaborative. So based on this, well, it raises a question. Is there sort of a time window or limit as far as what we can do and when we should stop? And so maybe it was 7.3 hours. But it certainly raises a practical question. But what about patients who present with wake-up strokes and they present at 10 hours since the last known well? So should we sort of stop and ignore them based on the suggested 7.3 hours of last known well, maybe the inflection point based on the Hermes analysis? Well, this was again kind of already being analyzed with the DAWN and the DIFFUSE-3 trials. They were already ongoing at the time that Hermes was being published, and these other trials were either wrapping up or halted early. And so these two trials specifically looked at beyond the 6-hour window of last known well. They're a little bit different how they were kind of designed. DAWN was sought to identify if there's a benefit for thrombectomy between 6 and 24 hours since last known wells in patients who had a large clinical to core infarct mismatch. Therefore, meaning that they have a high stroke score, 10 or greater, with a small core infarct on advanced imaging, perfusion imaging. So that was what they were looking to try to answer. DIFFUSE-3 kind of looked more at the kind of imaging mismatch. So between 6 and 16 hours of last known well, is there a benefit? But looking specifically at perfusion imaging, looking at the core versus the penumbra. So you want a relatively smaller area of completed or core infarct with a relatively large area of ischemic or penumbral tissue that's salvageable. So that's where the difference was. In the DAWN trial, looking at the clinical, the NIH stroke score versus the core infarct, and then the DIFFUSE-3 looking at simply the neuroimaging alone mismatch. So DAWN was published first the beginning of 2018, and this is sort of the breakdown of the trial design, pre-stroke modified Rankin of 0 or 1. I'll go through kind of what were their sort of criteria as far as age, core volume of infarct, and stroke severity by NIH. But as I mentioned, all were 10 or greater with these additional selection criteria, which we'll outline. On the baseline imaging, no minimum aspects per se, but less than 1/3 of the MCA territory involved is the core infarct. CTA or MRA as far as identifying the large artery occlusion, and perfusion imaging or diffusion weighted imaging to assess the core infarct volume. And then again, looking for that discrepancy between the clinical score, so an NIH of 10 or greater, versus the core infarct size on the advanced imaging, and again, between 6 and 24 hours of last known well. These were the sort of strata that were in the DAWN trial. So one group, and really this is the above 80 group, they were kind of the most strict with, in a sense. They wanted a core infarct that was basically as small as you can get, basically 21 cc's or smaller of the core infarct volume, but with that minimum NIH of 10 or greater, and that's again for the patients older than 80. Patients younger than 80, they kind of had two different strata. One was a relatively small core infarct up to 31 ml with an NIH of 10 or greater. But if you had an even worse or more severe stroke with an NIH of 20 or greater, they allowed for a little bit more core infarct, up to 51 ml. All of these are kind of considered relatively small core infarcts. Again, going back to the 2013 trials, some of them allowed for up to 70 mLs of core infarct. And so they were quite sort of tight with the stratification and selection criteria in the DAWN trial, really trying to, as best they could, answer the question and maybe prove the point that thrombectomy beyond 6 hours, is beneficial. They halted early. They got up to 206 patients with a fairly even split between the two arms. As you can imagine, because all of these patients were beyond 6 hours, it wasn't zero, but very few patients received IV TPA. So in essence, this was purely looking at the natural history of a large artery occlusion stroke beyond 6 hours versus that same stroke scenario plus thrombectomy. And so the median NIH stroke score was 17. The median core volume of the infarct between the two arms, 7.6 ml in the endovascular arm and 8.9 ml in the control arm, not statistically different between those two. This was a sponsored trial by Stryker, so the Trevo stent retriever was utilized in all of the endovascular cases, and they achieved a good revascularization rate of 84.1%. But when you look at the 90-day MRS outcomes, hugely different outcomes, more than threefold improvement in outcomes at 90 days between the endovascular arm versus the medical management arm. As I mentioned, it's sort of a bit of a natural history study in a sense in the medical management arm, because you've identified a large artery occlusion, but because at that point in time the question wasn't answered, we had to sort of analyze and say, well, what would happen if we don't do something versus if we do something? Granted, that wasn't necessarily a shock to say that they're going to do poorly because they've had a large artery occlusion stroke, but nonetheless, that was the trial design to really answer specifically the question, is there that benefit beyond 6 hours? And of course, the answer was yes in this trial. When you look at the modified Rankin 0, 1s, and 2s, of course, in the control arm, very few had good outcomes. So just about 13%, as we saw, had good outcomes in the control arm, with almost 50% having good outcomes of 0, 1, or 2 in the thrombectomy arm. But again, even looking at the relative shift in modified Rankin, so 3s and 4s, for example, again, very poor outcomes, relatively speaking, in the control arm, a lot more of those modified Rankins of 3s and 4s versus in the thrombectomy arm. So perhaps they're not completely independent, but you've significantly reduced their disability, and maybe they're still an MRS of 3. So again, there's that potential added benefit for those who are not considered as the optimal 0, 1, or 2 outcome. When you break down kind of the different strata between the times, so 6 to 12 hours since last known well versus 12 up to 24 hours since last known well. Not that many patients were really in the very far end of the spectrum, 18 to 24 hours, but nonetheless, they of course had patients. But when you break it down, the end result still carries true, whether you're presenting in the 6 to 12 hour window versus the 12 to 24 hour window between the outcomes. So again, there's sort of some added data that we can see here showing that there's benefit up to 24 hours since the last known well. So the conclusion, of course, was that there were significantly better outcomes with thrombectomy in patients with this large clinical or NIH stroke score versus core infarct volume mismatch between 6 and 24 hours of last known well. The number needed to treat for a modified Rankin of 0 to 2 at 90 days was 2.8 patients. I know Sabine talked about this the other night in his talk, but there's very few things in medicine that have an NNT of 2 or 3, and a lot of these stroke trials have really made it so low as far as the number needed to treat. That's what's making it so exciting. There's so many people we can help with very small NNT to provide benefit. And in this trial, they even found that the NNT was 2 just to decrease the disability. So maybe it's not necessarily the independent outcome, but at least you're significantly decreasing the disability. So that's basically every other patient that you can help as far as looking at the NNT from this trial. The DIFFUSE 3 trial was published a little bit later. It was simultaneously published and announced at the International Stroke Conference this year. So again, looking at 6 to 16 hours since last known well, and again, using a variation rather than the clinical to core mismatch, they looked at the perfusion imaging and using rapid software, as we mentioned earlier with the Extend-IA trial, but using that to define a core volume of less than 70 mLs with a mismatch ratio of greater than 1.8, meaning that there's more than 1.8 times the ischemic or penumbral tissue as compared to the core infarct tissue. Oh, and a mismatched volume of more than 15 mL. So more than 15 mLs of difference between the penumbral tissue you're trying to save versus the core infarct volume. So putting that together, using that imaging criteria to select patients between 6 and 16 hours since last known well. They actually allowed for pre-stroke modified Rankin of up to 2, so a little bit different than a few of the other trials. Here's an example from the paper from the trial showing kind of the color maps that get generated by the RAPID software. In essence, what it'll do is look at the raw data from the perfusion imaging and automatically calculate the core infarct volume. So in this example, this patient had a wake-up stroke. They did the RAPID process, and the program came up with a core infarct volume of 23 milliliters with a perfusion or ischemic area that's relatively able to be salvaged of 128 milliliters. So the mismatch ratio, 128 divided by 23, you get 5.6. And of course, the absolute difference was 105 ml. So it met the criteria for this trial of this patient, and happened to be that this patient had a very high stroke score of 23. So this is just an example from this trial of how that RAPID software influenced their decision making. So they also halted early at 182 patients, basically an equal split between the two arms. Very high median aspect score of 8. So again, on the dry head, overall good brain as far as not too much loss of gray matter differentiation. And NIH stroke score median was 16. Small core infarct volumes between the endovascular arm of 9.4 milliliters versus the medical management arm of 10.1 milliliters. And then the median ischemic tissue or penumbra, you can see quite large, 114 milliliters on as a median in the endovascular arm, 116 milliliters in the medical management arm. So really, they in a certain sense, they selected for very good patients, very small core infarcts for very large ischemia, but that's part of that trial design, trying to optimize who can we help between 6 and 16 hours. They used a variety of thrombectomy devices. It wasn't sponsored by any one particular device trial, device manufacturer. So they could use basically whatever device they would like. They found a good revascularization rate in 76%. And you look at the good outcomes at 90 days of modified 0, 1, or 2. Again, very good difference in outcomes, quite similar to the DAWN results. In DAWN, it was 48% versus 13%. In the DIFFUSE 3 trial, 45% versus 17%. So in a certain sense, it kind of not only confirms that beyond 6 hours, there's a benefit to thrombectomy, but also kind of confirms, well, the natural history of non-treated patients in the control arm is pretty poor. And so again, part of the reason why both trials were stopped early, because there was not equipoise anymore, but nonetheless, there's some kind of confirmation of the data points between these two different type of trials. Again, the data from the DIFFUSE 3 trial shows not just the improved outcomes of 0, 1, and 2, but also that relative Rankin shift of the 3s and 4s in particular. So conclusion is that there's significantly better outcomes with thrombectomy for patients with this large core to penumbra mismatch presenting between 6 and 16 hours at last known well. Again, a very small NNT of 3.6 patients to derive that benefit in independent outcome, modified Rankin of 0, 1, or 2 at 90 days. So again, kind of quite in line with the DAWN trial. So with these additional trials, as well as some of the other ones as we've talked about earlier, but of course, the American Stroke Association had to yet again update their guidelines just this past year, another exciting international stroke conference. And so some of the changes that came about in the guidelines this year, well, based on the DAWN and DIFFUSE 3 trial, they said that it's got level 1 evidence to offer thrombectomy for patients presenting between 6 and 16 hours of last known well with a large artery occlusion. Now they specified, because those were the two trials that they of course utilized the data from, that they meet these DAWN and DIFFUSE 3 type criteria. So trying to figure out, is there a large clinical to core mismatch or a large imaging mismatch but using that to select and giving it level of evidence class 1. You can consider thrombectomy for patients between 16 and 24 hours since last known well. Since Dawn was the only one that had data beyond 16 hours, that was considered class 2A type of level of evidence, but nonetheless, very reasonable to consider that. Some additional changes which were interesting and improved upon, in my opinion, from the 2015 guidelines were, well, to consider thrombectomy for not just what's considered the M1 or the very proximal middle cerebral artery, but now getting into, for example, the M2, the next level divisions or branches, even out to the M3, for example. In some cases, that's technically possible. Other arteries such as the anterior cerebral artery, or even now there was other data and trials that came out looking further at the posterior circulation. And so they said it's level 2B, but nonetheless, you could consider thrombectomy for these kind of patients. Additionally, sort of an expansion based on these additional trials that had come out, including these Dawn and DIFFUSE 3 trials, but to consider thrombectomy for somebody whose baseline function was not just 0 or 1, so maybe a 2, for example, like in the DIFFUSE 3 trial. The NIH stroke score lower than a 6, you could consider that. Some trials did not have a bottom end cutoff as far as the NIH stroke score, or even an aspect less than 6. So considering, well, maybe patients who already have apparently a fairly sizable volume of core infarct, but maybe they still derive a benefit. Not as strong evidence, certainly for some of these other recommendations, but still some evidence exists that these are some things worth considering. So what are some of the things that are maybe coming up next? Well, one of the other trials that was announced and discussed at the International Stroke Conference this year, which I thought was a very exciting trial, was another one from the Australia group, again led by Bruce Campbell, called Extend IA TNK, so Tenecteplase. So what they look to do is actually compare not the thrombectomy side of things, but in fact to kind of compare the actual medical management or the Tenecteplase, which is not yet considered as a standard of care treatment for IV therapy for stroke, versus alteplase, which has been a standard of care since the 1995 NNDS trial. And so this is sort of how the trial worked. There was TPA plus thrombectomy, so standard dose of TPA is 0.9 milligram per kilogram up to a maximum dose of 90 milligram, with a 10% bolus dose plus then a drip, versus Tenecteplase, TNK, which in this trial they used 0.25 milligram per kilogram, and it's a bolus dose. So that's sort of very interesting and has some potential practical implications. Rather than what's commonly referred to as drip and ship with TPA, it's possible that you can get a bolus dose of TNK, a one-time dose, and get shipped out the door. So nothing is really dripping, and you perhaps transfer to an endovascular center to get the thrombectomy. One of the other very interesting things in this trial they found was that the Tenecteplase arm was not only superior, but in fact, 1 in 9 patients already achieved recanalization of a documented large artery occlusion by the time they got to angiography. I can tell you it's not that this is impossible with TPA. In fact, just last week, I had a case where a patient had an M1 occlusion that by the time they got on the table, it had resolved with the TPA. Doesn't happen often, but it can happen. But in this study, it was interesting that this happened in up to 1 in 9 patients. So perhaps that reveals a superiority and more specificity for fibrinolysis with Tenecteplase as compared to TPA. And again, as I mentioned, maybe a practical advantage of the TNK is that it's a bolus dose only versus bolus plus drip. So this was the breakdown. Again, this trial really goes to look at the medical side of things, not actually the thrombectomy piece. The thrombectomy was common between the both groups, and they both achieved very similar rates of revascularization from the mechanical standpoint. So nonetheless, this is, I think, a good trial and maybe some future direction to utilize Tenecteplase, perhaps as an alternative to alteplase as far as the medical side for treating stroke. Another trial, which is now started and ongoing, hopefully maybe by late 2019, we'll have some at least preliminary results, is what's called the SWIFT Direct trial. So this is a trial now looking to really compare thrombectomy versus thrombectomy plus stent retriever, to kind of really say, is there, if you will, an advantage of giving alteplase to patients, or maybe they just need the plumber to go in and physically remove the blockage with thrombectomy alone. And so the criteria looking at this, we don't have any kind of data at this point, of course, because it's, just started and ongoing. But they do want to, of course, randomize no later than 4 hours and 15 minutes. So you're really kind of more in the much more acute phase. So not even out to 6 hours, such as in the SWIFT Prime trial. So they wanted actually even shorter than that, because they want to make sure that if patients are randomized to IVTPA, that they get it within that 4.5 hour window, which is current standard of care. Another trial that's ongoing is the REVASCAT trial. This is done by the same group that did the REVASCAT trial, so the groups out of Catalonia, Spain. Now this is looking at an idea that, is there an advantage to direct transport of a patient to the closest local stroke center that maybe does not do endovascular treatment versus directly going to an endovascular center and looking at the outcomes. So this might finally answer the question, which is a burning question in a lot of people's mind, about whether or not there's an advantage to directly shipping somebody versus let them get to the closest center first, perhaps get TPA, and then drip and ship them to somewhere else. So hopefully we'll have some data from this, again, maybe late 2019. So in conclusion, endovascular thrombectomy truly is standard of care, certainly based from those 2015 trials onward. We have now multiple randomized controlled trials showing the efficacy for thrombectomy of large vessel occlusion, acute ischemic stroke between 0 and 6 hours, based on certainly the 2015 trials and most of those 2016 trials. But then more recently, DAWN and DIFFUSE 3 shows a benefit expanded out to 24 hours since last one well. So really, that has had not just a huge impact on patient care, but really has allowed for a huge paradigm shift in what can happen for stroke patients. If you imagine unfortunately, just a few years ago, potentially a patient showing up 12 hours since last known well with a large artery occlusion, the data didn't support doing anything about it. And so when we look at the natural history from the DAWN and DIFFUSE trials, the control arms, unfortunately, those patients do very badly, and we knew about that. So now we have some data that says we really have a standard of care with very good evidence to support doing an intervention to help these patients out, and they clearly have better outcomes. Future directions, well, the REVASCAT trial and others may try to answer the question about bypassing. So skip the local center and go straight to the center that has endovascular capabilities. Maybe Tenecteplase will be the new wonder drug rather than TPA. Maybe Swift Direct and other trials will say, well, you don't even need the drug, just take them for thrombectomy. It's a plumbing problem. The plumbing is blocked. We need to get it open as quickly as possible. Maybe there will be further similarities with the myocardial infarction STEMI world, where in the past they used to do dosing of TPA, systemic dosing, and then they figured out, well, it's much more of a mechanical issue of getting the artery open as quickly as possible. So perhaps that's what needs to be done. So we'll see what future directions come of that. And so with that, happy to answer any questions that are out there, and certainly feel free to email me anytime with any other questions. Thank you very much.
Thank you, Dr. Vadlamudi. That was an excellent presentation on all the literature that's out there on stroke intervention. We do have a couple of questions. Probably have a time for just 2 of them here.
Sure.
First one is, what do you think the future of the further trials is? Do you think that current devices are good enough for the majority of cases of thrombectomy?
I think, at least trying to, predict the future, if you will, like, I think that maybe even in 5 years or shorter than that, we'll not only have better devices coming out, but we might even get to a point to say, wow, our devices were really crude back in 2017 and 2018. We have so much better devices. That also being said, I think there's other advances going on in the area of using things like nanomedicine or shear stress activated fibrinolytics. So there's other things that perhaps may be adjuncts to our mechanical tools. Right now, when we do a thrombectomy, in essence, you're either actively sucking out the clot, or you're using this stent on a wire, this stent retriever technology, and you're physically grabbing on and dragging the clot out. It works well, as obviously seen by these multiple trials, but perhaps down the line we'll have better tools and perhaps better medicines to go with those tools that really will make it a much more efficient mechanical process with a much higher rate of revascularization. But at the same time, I think still what eludes us at the moment is correlating those angiographic outcomes with the clinical outcomes. So maybe that's part of what we have yet to truly understand. If you look across all of the data from all the different trials, not one of them had the 90-day MRS percentages equal to the angiographic TICI 2B and 3 outcomes. So what is that discrepancy? Maybe with better technology, better devices, better medical management of these patients, we can sort of close that gap.
All right, great. Last question here. It seems that the most recent endovascular literature is focused on anterior circulation strokes. What is the state of literature for posterior circulation stroke thrombectomy, and what has been your approach to such cases?
Sure. So I think posterior circulation stroke has remained a challenge. I think most people who do interventions probably feel that there may not be real equipoise to be achieved with posterior circulation stroke. We do know some degree of natural history data of basilar artery occlusion. It unfortunately has the potential of having very high mortality, up to 90% at 3 months may be dead. So it's pretty hard to kind of randomize, knowing that as the background. Now, that being said, there's certainly nuances to basilar occlusions. Not everyone is exactly the same, but nonetheless, I think that's remained the challenge for posterior circulation strokes. That combined with the fact that they're not as common as anterior circulation stroke, so the split is about, on average, maybe about 80 to 85% of strokes are in the anterior circulation, 15 to 20% are in the posterior circulation. So you're already, getting a smaller number as far as the potential to randomize. But again, I think a lot of, endovascular interventionalists will struggle to randomize patients to not being treated for their posterior circulation, especially basilar occlusion. In my practice and in our group's practice, in essence, we don't pass on those patients. So we will almost always take those patients for thrombectomy, unless there's really an MRI or something documented that the brainstem is completely infarcted. Basically, there's sort of nothing to be gained by opening it up. We will definitely give them the benefit of the doubt of opening up that artery, just sort of knowing what the potential mortality rate could be.
All right, great. On behalf of the RFS, Dr. Vadlamudi, I'd like to thank you for taking the time to present tonight. And I'd like to thank everybody for their questions and for attending tonight. Again, all the other stroke webinars will be posted on the YouTube channel soon. Thanks again.
Thank you, everybody. Good night.